Dr. Jori, who kindly accepted. In behalf of the kidney transplant team, I welcome you both. And please, Marisa.
Obrigada, Rosana. Eu vou falar em português, porque senão vocês vão achar estranho, mas a Jori está aprendendo no momento. She's learning on the fly. Mm-hmm. So, como a Rosana, como vocês já sabem, eu sou amiga da Rosana, eu me formei com ela em 83, e eu trabalho como patologista clínica na área de banco de sangue e coagulação. Quando ela pediu para falar sobre esse assunto, eu pensei que a pessoa melhor para falar era a Jori. Jori foi a residente de medicina interna, residente de hemato-onco, e agora ela é faculty member, ela é professora daqui, e ela é a melhor pessoa aqui para falar para você sobre isso. Ela é incrível, é excellent. Então, ela preparou uns slides baseados nos slides nas perguntas que a Rosana mandou, mas são poucos slides, tem tempo para fazer pergunta e responder. E se alguém quiser perguntar alguma coisa em português, pode perguntar, eu falo para ela. Ou a Rosana me manda, eu tenho meu celular aqui, pode me mandar por WhatsApp. Então, vamos tentar fazer que seja útil para vocês. A gente sabe que vocês estão no meio do dia, nós também estamos aqui no meio do dia. E podemos começar, então. Tá bom?
Perfeito. Pode compartilhar a tela dela. Please, Dr. Jori, feel free to start anytime. We started recording.
Okay, great. Yes. Share. Let's make this big.
Mm-hmm. Mm-hmm.
Okay.
Do you see one slide?
Yes.
Okay.
Well, great. Thank you so much for having me. It's really an honor to be with you today. I only wish I could speak Portuguese, but I will try to speak clearly. Please don't hesitate to ask questions or unmute yourself. I think I caught a bit of what Dr. Marques said, but we basically created some very brief slides just based on the questions that we received, and certainly would be happy to have conversations about specific examples or other questions that aren't covered. So I will go ahead.
That's what I said.
Oh, perfect. Well, I speak Spanish, so at least there's some similarity.
Yes.
So basically what we'll do today is talk about the different antithrombotic therapies, and there were similar questions for each of them. So how do we need to evaluate their presence in a patient? How long do they last? And what do we need to do to avoid bleeding? And so I use the term antithrombotic therapy, which refers to both antiplatelet therapy and anticoagulation. And so basically we will attempt to address each of these questions for each of the different agents that we're going to talk about. So we'll start with talking about antiplatelet therapy. The question is, so if a patient is taking something like, most commonly in the US, we think about aspirin or clopidogrel, which is Plavix. What do we need to do if a patient is coming in and potentially needs transplant or some other procedure and they're on antiplatelet therapy? Is there some sort of initial laboratory testing that we need to do? Really, there's not. So the initial hemostatic evaluation is really none. There are some studies that we use, the platelet aggregation studies, that sometimes are used to assess for the kind of degree of platelet inhibition by these medications. But those studies really aren't particularly helpful. What's most helpful is really the patient history. When did they last take the medication? And really, why are they taking the medication? At least in the United States, we sometimes find that patients have been placed particularly on aspirin without a clear indication for it. So I can think of maybe a situation where you have a patient who's anticipating transplant. They have aspirin on their medication list. It's often worth having a conversation first and foremost about whether they actually need to be on that medication, so that when the time comes for transplant, rather than chasing your tail to try and figure out how to deal with the aspirin, perhaps we can stop it in anticipation of going to transplant. But if you do have a patient that is on antiplatelet therapy, how long does the effect of those medications last? Aspirin, the effect is thought to last about 7 to 10 days. It causes irreversible inhibition of platelet function. So basically it binds to the platelet and acts to inhibit function. And the only way that we are able to overcome that is by the body actually making new platelets. That's estimated that basically platelet function does start to normalize by 10% per day. So basically as the body is making new platelets, we start to see some improvement. There is some suggestion that you don't necessarily need that full 7 to 10 days in order to have normal hemostatic function. That perhaps, just as we know in a patient with a low platelet count, a platelet count around 50 is not normal, but is usually enough for hemostasis to occur. So similarly, it's maybe not that you need the full 10 days for aspirin to wear off, but then even within those early first few days, there's enough platelet function for hemostasis to occur. Clopidogrel or Plavix has a little bit of a shorter duration of about 5 days. It also can cause kind of a duration of inhibition that is variable, but kind of the hard stop is that it's completely out of the system after 5 days. So what do you do to avoid bleeding in a patient that is on antiplatelet therapy? If there's time, right, we all know we want to hold it before surgery if possible. I will say it's often helpful to talk to the surgeon about what they actually think might be tolerable during surgery. Some surgeons here in the literature will operate on aspirin 81 milligrams, which is kind of our standard low dose aspirin that we use in the United States. So it may not be necessary to even hold the aspirin if the surgeon thinks they're comfortable with proceeding while they're on that agent. Clopidogrel, folks tend to be less comfortable. It is stronger platelet inhibition and may be associated with stronger risk of bleeding. So often that medication, at least in the United States, is held before surgery. So what do you do if you have a patient who's on antiplatelet therapy and they develop bleeding? There's really not data to tell us exactly what to do here. What we often see is the use of platelet transfusion. So basically we give additional platelets hoping to overcome that inhibition from those agents. The challenge is there are some studies that suggest that's not particularly helpful, and being good stewards of blood products, which is something Dr. Marques always advocates for, it's hard to know if that's truly beneficial. There are some who use DDAVP, that kind of a small dose to basically increase the desmopressin. In
case they don't use DDAVP,
I don't know if that abbreviation is something that translates, but desmopressin to basically increase platelet release, increase factor VIII and von Willebrand factor release. This might be particularly challenging in your renal transplant patients due to the risk of SIADH or syndrome of inappropriate ADH, where basically we can develop holding on to free water and hyponatremia. Want to make sure that translates. So I think that's something I would be hesitant to use in your patients where there are concerns about using excess IV fluids or any concerns about being able to monitor output or sodium levels reliably. So that's a general overview of how I think about antiplatelet therapy. Maybe I will stop there and pause for any potential questions or comments before moving on to anticoagulation.
Yes, as you know, most of our transplants are from kidney donors. So we don't have this time to plan, to stop before. And then sometimes they call this diffuse bleeding because of the aspirin or these platelet, these other drugs, clopidogrel or ciclopidine. So do you believe that we should consider platelet transfusion in this setting? We do have DDAVP, it's the same abbreviation.
Okay.
But we are also concerned with thrombosis, adverse effects of DDAVP besides CAGH.
Mm-hmm. Yeah.
I guess platelets.
Yeah, platelets is really, in my practice, that would be the first thing I would turn to, is if we do think that bleeding is really related to being on antiplatelet therapy, transfusion of platelets is probably going to be your safest option.
We also concerned with the antigen characteristics of the platelets because of the, the rejection
Yeah, but remember,
problems. I don't know if they are so antigenic as
no,
leukocytes, so hemoglobin.
platelets only have class 1 HLA.
Oh, that's better.
And so we don't, unless the unit is non-leukoreduced, which I believe all yours would be, if the white cells have been removed by filtration, I think all of them are in Brazil, then I wouldn't worry about rejection from the platelet.
So this is one of the things, practical things we can start to
Ask the blood bank if the units are leuco. I don't remember how they call it in Brazil, but they have they should have removed 99.99% of the white cells, which would include the lymphocytes and the neutrophils that would have the class 2 antigens that you worry about. Platelets by themselves only have class 1. Shouldn't be a big problem for tissue rejection.
Okay, thank you. I don't know if anyone here has questions. We have to talk here, but the audience in the meeting can also please feel free to ask questions.
Okay, or she can continue if you want, and then we can ask.
Pessoal, quem está no Meet, se quiser fazer perguntas, só ligar o microfone e fazer, tá?
Sempre mais fácil. Perguntas. Sim. I didn't know you knew.
Okay, I believe you can continue.
Okay.
Then.
Keep going. Great. So we'll move on to the different anticoagulation agents. Warfarin is the one that has been around the longest and is really the most straightforward to deal with because we have a laboratory value that we can follow, right? So we use the International Normalized Ratio, or INR, which I don't know if that abbreviation is the same for you, but that allows us to, we check the INR, we know how much warfarin is in the patient's system. The duration of effect is variable. It depends what the INR is at the time, basically to how long it can get out of the system. Usually we're talking about 3 to 5 days without any sort of intervention is how long it takes the body to basically clear that vitamin K inhibition and start making sufficient clotting factors in order to achieve normal hemostasis again. So what do you do for bleeding and warfarin? Again, this is a more straightforward. So first having a conversation with the surgeon about what is the threshold for INR that they're comfortable with. Again, in the United States, different surgeons have different preferences. So I do find oftentimes I'm speaking to that individual surgeon in order to figure out what our goal is in order to make sure the patient is safe for surgery. So if you have time, which as you mentioned, oftentimes you don't, the ideal thing is to hold and to give vitamin K. Allow time for that warfarin to be cleared and then provide the vitamin K in order for us to overcome that inhibition of warfarin. Usually a single dose of 10 milligrams orally is sufficient. There's no data to suggest that giving IV is any better than giving orally, as long as the patient doesn't have any reason to have impaired absorption. And the IV, at least in the United States, is more expensive. One thing to think about is actually why they're on the warfarin. So some people do require bridging, meaning a term that we use for using a heparin product to avoid prolonged periods off of anticoagulation and to potentially avoid the prothrombotic phase that happens when you restart warfarin. Fortunately, the pendulum has kind of swung in the other direction on bridging. It used to be we thought we had to bridge everybody, so any patient on warfarin for atrial fibrillation, but we now have studies that show us that's probably not necessary. When I think about my practice, who am I still using bridging for? I'm bridging people that are on warfarin for valve replacement because they are extremely prothrombotic. And I do use bridging in people who have antiphospholipid syndrome because of the concern that those fluctuations in warfarin levels can precipitate catastrophic antiphospholipid syndrome. I think, someone might be unmuted, I think. So if there is not time to wait for vitamin K and to hold the warfarin.
Should we wait to see what's going on?
Oh, I think it's fixed.
Okay.
I think we're good. So if there isn't time, then we talk about using 4-factor prothrombin complex concentrator, PCC. Dr. Marques has let me know that I think you use Baraplex in Brazil. And so that's the standard agent that we use in the United States in order to reverse the effect of warfarin. Important to remember that before we had 4-factor PCC, we talked about using FFP or fresh frozen plasma. But studies have consistently shown that if we're talking about the need for emergent reversal, 4-factor PCC is able to provide more rapid reversal at a much smaller volume. So that is the preferred agent. There's a lot of debate about dosing of 4-factor PCC. I've included a reference here as a recent trial looking at this question of, does it need to be a weight-based dose, which is kind of the standard dosing strategy, versus using what we call a fixed dose strategy, meaning that every patient is basically getting a standard dose. There's a lot of debate about this because the fixed dose strategy has the benefits of lower doses. So from a cost perspective, you're potentially using less. And also from a system perspective, if the dose is standardized, there's been data to show that we can get that agent to the patient faster. So potentially that does improve hemostatic outcomes as well. The fixed dosing strategy, you'll see, at least in the United States, there's a lot of variation in practice, but in general, it includes a dose of around 1,500 to 2,000 units as an initial dose, and then a repeat INR checked about 15 minutes after completion of the infusion. You can then give an additional 500 units if you want that INR to be less than 1.5. So at UAB, we're talking about making that transition right now. Right now, we are still weight-based, but I do anticipate we're going to move to a fixed dosing strategy. So what do? After you give PCC, we do tend to, the first INR check about 15 minutes after is worth doing if you're using a fixed dosing strategy, and then continued follow-up every 6 hours, because the challenge is that you need to, the effect of the PCC can wear off and the body is not yet making its own clotting factors. So repeat dosing may be required. So important, particularly in those first 24 hours, to keep an eye on the INR. And to remember, you're not giving the PCC alone, you're giving it with vitamin K, because the PCC is temporary. You need to give the body vitamin K to start making its own clotting factors in order to overcome that effect. So that's a general approach to warfarin management and reversal. And maybe I'll pause there as well to answer any questions or comments.
Hi. May I ask a question?
Please.
Yeah. My question is about, these patients are using warfarin for, like atrial fibrillation or maybe other causes like thrombophilias. So how we manage, because it's a balance. You don't want your patient to bleed in the surgery, but at the same time you have so when we are supposed to manage after the surgery, this balance with avoiding bleeding and avoiding the complications of the disease, the basic disease.
That's a great question and a great point. I think that's the biggest challenge, and why the first option is always the best if there's time to kind of take the slow road, right? Because using these reversal agents, we know this comes with an increased thrombotic risk. That's the thought between the fixed dosing strategy, is really using the lowest possible dose. So potentially the fixed dose oftentimes ends up being a lower dose than what weight-based dosing would have been. And so perhaps there's kind of a slight decrease in clotting risk if you are using a 4-factor PCC at a fixed dose.
And then in the post-op, I think you're also talking about
post-op.
Post-op, right?
Yeah.
The post-operatório. Maybe what do you think of if the risk of clotting is high, like in the AFib or even in the valve or antiphospholipid syndrome, use a little bit of heparin,
Oh, yes.
because then you can heparin, heparina, you can stop with protamine very fast if there is bleeding, but the heparin prevents the thrombosis, and it can be stopped if there's bleeding.
Correct.
Right?
Yeah.
That's in the post-op when you're worried about the clotting from the original disease and the bleeding from the surgery. Do you use, vocês têm anti-TNA no hospital? O fator 10A ativado, antifator 10A, ou usa?
Eu acredito que sim. I believe so.
Yeah, they are telling me that yes. No, it's not easy.
É o melhor.
It's expensive, but yes, we do have.
And we have the support of the blood bank. So they are very good. They help us a lot.
O teste é feito 24 horas por dia?
Claro que não.
Não.
Não, acho que não.
Because the heparin, nós usamos esse teste para monitorizar a heparina, porque assim, porque é o muito mais
Curado.
Preciso do que o TPP, que chama lá, PTT. Então é outro probleminha com a heparina, é que se tu não pode usar o 10A, a dificuldade é saber o quanto a heparina o paciente tem, porque o teste da tromboplastina é muito afetado por muitas coisas. Então, aliás...
Porque no transplante, Marisa...
Oi?
E ainda considerando que no transplante, eles são urêmicos.
Eles estão o quê?
Eles são urêmicos, estão em diálise, então a meia-vida da heparina é prolongada ainda.
Exato, pois é. Então por isso mesmo que tem que usar o melhor teste possível. Mas se não, então é problemático usar a heparina, mas pelo menos se há sangramento, mesmo sem saber quanta heparina tem, dá para usar protamina. Even if you don't know exactly how much heparin, if the patient bleeds, you can give protamine, a small dose, right?
I have a question. In Portuguese, because it's difficult. Marisa helps.
Yeah, you can ask in English.
Marisa, o meu inglês já acabou até agora. Marisa, só retomando. Então, ali, voltando para a varfarina. A vitamina K é essencial, que pode ser oral EV. Aí o 4F ali é o plasma fresco congelado, é isso?
Não, é o Beriplex. Não, Beriplex é o...
toda aquela sigla é o Beriplex.
Gente, é Beriplex, que é o complexo protrombínico, mais vitamina K, não é isso?
Não,
o que é o PCC?
Não. 4-FPCC é o complexo da...
É o nome todo, tá, do Beriplex.
Tem 4 fatores.
Complexo protrombínico.
Isso, tem 4 fatores, 2, 7, 9 e 10. Porque antigamente tinha
Exato.
Tinha 3.
Então, a primeira indicação é o Beriplex.
Primeira indicação é Beriplex. Plasma, quase nunca. Plasma é FFP, o que ela escreveu ali.
Agora entendi melhor ali.
Eu acho que nunca deve...
Até porque o volume de plasma que precisa ser administrado para tentar reverter em relação ao Beriplex, né? O volume de plasma é bem maior.
É enorme. É litros.
Exato, pode causar congestão, né? Aquela taco que a gente chama.
Isso. Na minha cabeça, a quantidade de plasma que necessitaria, colocaria o plasma numa banheira e põe o paciente dentro da banheira, porque não tem quase como dar 2 litros.
Isso. E sem contar que o plasma leva até 3 horas para fazer o efeito, né? E o Beriplex não, é bem mais rápido.
Não, o plasma faz efeito à medida que tu vai dando, mas é que tu não pode dar muito rápido.
Exato.
O Beriplex vem aqui, a gente tem 1.000 unidades, que seria metade de 2.000, em 40 ml. E para dar 1.000 unidades de plasma, seria 1.000 ml, 1 litro de plasma. Leva horas para dar 1 litro de plasma, e quase ninguém consegue receber 1 litro, a não ser que esteja sangrando, transfusão maciça. Então, tá claro, Rosana?
Okay.
Okay. Next.
Thank you very much. You can continue. Keep going.
Okay, great.
The good thing is that Beriplex is here too.
Oh, yeah, perfect. Yeah, so let's move on to the oral factor 10A inhibitors. So this is apixaban and rivaroxaban, which are the 2 agents we use most commonly in the United States. I'm not sure if you guys use the agents edoxaban or batrixaban.
They do it. I don't know yet.
Yeah, but I can speak from our experience with apixaban and rivaroxaban.
They have an A at the end, apixabana.
Apixabana, okay.
And
Apixabana and rivaroxaban. So unfortunately for these, we don't necessarily have a laboratory value to tell us how anticoagulated a patient is. These agents will affect the PT and the PTT as well as the anti-10A, but not in a predictable fashion. So if you have a patient who's taking one of these agents and you check one of those laboratory values, if it is super abnormal, very high, that does not necessarily mean that they are over anticoagulated. And also, if it's only mildly elevated, it does not mean that they are under anticoagulated. The only thing it really tells you is the agent is there or the agent is not there if the anti-10A is completely normal. So there's no real laboratory testing that's helpful here. You know, the variation of effect, the duration of effect is variable. In general, we think about clearance of these agents in 2 days from circulation. But of course, this depends very significantly on renal function. As we know, these agents tend to be renally cleared primarily. It also depends on the dose. So there's a lot of new dosing strategies using lower doses of apixaban and rivaroxaban. So full dose is considered 5 milligrams twice a day for apixaban or 20 milligrams daily for rivaroxaban. But there are some patients who qualify for decreased dosing. So 2.5 milligrams twice a day for apixaban versus 10 milligrams once a day for rivaroxaban. So the dose also is worth exploring with the patient to help fully understand how long you can expect the effect to be present. So what do you do if you want to avoid bleeding? Again, holding is our best option, but I recognize that's often not possible for your patients. So I think you confirmed that you do have an anti-10A assay. Remember the anti-10A, right? These anticoagulants act on 10A. So the anti-10A assay can look for that effect. Again, it's a yes, no. So if it's abnormal, that means the drug is there. If it's normal or undetectable, that means the drug is not there, but it does not tell you how anticoagulated the patient is within that lab value. So again, here we have our options for reversing these agents are the Beriplex that we talked about before, the 4-factor PCC. There is an agent now called andexanet alpha, which I think we confirmed that you guys do have access to. I'll pause here to say, and I think this question was brought up before, understanding why the patient is on the agent is important and helping us pick the best strategy and worrying about and estimating thrombotic risk. So with andexanet alpha, at least in the United States, we do not have the ability to use this for perioperative reversal. It's only approved in a patient that is having some sort of life-threatening bleeding. So it's not something that we give prior to surgery at this point. So say a patient is on apixaban and they need to go for transplant, we do not use andexanet alpha. At our institution, due to cost, we actually limit the use of andexanet alpha only to intracranial hemorrhage. That is just an institutional decision. And I'll tell you, there are institutions in the United States who have opted not to even permit the use of andexanet alpha due to the cost of the agent and the fact that it has not been compared in randomized trials to 4-factor PCC, which is a more affordable option. So use is not universal in the United States, but it is an option for you if that is approved.
I doubt it is.
It's not, okay. So then 4-factor PCC or the Bariplex is really going to be your best option. And similarly here, there's a lot of debate on fixed dosing versus weight-based dosing. The kind of standard weight-based dose is actually 50 units per kilogram, but there's been some robust data to show that 25 units per kilogram is actually equally as effective and less costly. So particularly to the question that was brought up before, the concern about thrombotic risk, less is more. So I'm a big fan of using 25 units per kg if you can. There is a lot of discussion too about using fixed dosing for these patients as well, a similar dose of 1,500 to 2,000 units. The challenge here is that there's not a laboratory value to reassess. It requires a clinical reassessment for stability of bleeding because that anti-10A is not going to be reliable. And Dr. Marquez reminds me I'm talking too fast. I apologize. So these two, repeat dosing might be required. And unfortunately, that's a clinical call because there's no laboratory value to tell you for sure whether a patient needs a repeat dose or not. You know, these agents are cleared a little more quickly than warfarin. So the hope is that they don't require multiple repeat doses, but it is something to consider, particularly if there's concern for bleeding. And I again emphasize this in the monitoring, that it's really a clinical monitoring process. So I'll pause there again for any questions or comments.
Pode ser em português se alguém quiser, para não demorar também. Todos vão ter os slides e as referências e tudo. Não se preocupe.
Eu tenho uma pergunta. Então, eu acho que o ideal no paciente que está em lista de espera de transplante, que a gente não sabe quando é que vai ser, não é uma pergunta, tá? Vocês acham que o ideal, se possível, é evitar esses inibidores do DASI?
Ok, vou perguntar. Do you think it's the best thing on the patients on the waiting list to avoid these new oral 10A inhibitors?
I don't think so. I think the only question is, so the data that we have on these agents in people with severe renal dysfunction is really only in patients that are on anticoagulation for atrial fibrillation. So in general, I don't use these agents in patients that are on this for thrombosis, that are end-stage renal disease, that are on dialysis. I'll tell you, there's plenty of people that do, but I worry that the pharmacokinetics is so unpredictable, it puts them at risk for bleeding and thrombosis. And so I do tend to use warfarin in patients that are on dialysis, that are on anticoagulation for venous thrombosis.
So I guess you're avoiding, you feel like avoiding.
I do. I mean, I think for atrial fibrillation, there is some data to suggest safety.
But these patients are all on dialysis.
Right.
So they're
in the atrial fibrillation literature, there is some data with Eliquis, really. So with apixaban. But particularly, you know, if you're getting close to around the time of transplant and you want something that's more reliable to know that it's reversed or not, warfarin is going to be that agent. You know, I think it depends on the patient though, because being on warfarin is not easy. And so having to have laboratory monitoring and make the dietary changes is difficult. But I think if you have a patient who can do those things and you have the option to be on warfarin, it is going to be more predictable if you think they're going to transplant in the near future.
The problem is they never know.
You never know.
Because these are deceased donors.
Right.
That's the
well, and I think people who maybe are high on the list, right? So if you have people that you're not anticipating, you know, I think it's a challenge, but warfarin is definitely going to give you a more predictable degree of anticoagulation. And if you worry about that perioperative period, it's going to be the most easily monitored and reversed.
Should we go to the próximo slide por causa do horário?
Yes, please.
Okay.
So this is a change in topic. So the last question we received was about antiphospholipid syndrome. And so this is just a brief review. We can talk about some of the new specifics, but really the diagnosis the criteria that we use is the standard revised Sapor or Sydney criteria, which includes 5 laboratory assays. Those are listed here: the anticardiolipin, IgG and M, the anti-beta-2 glycoprotein 1, IgG and IgM, and the assay that's the lupus anticoagulant. There is a lot of discussion about other laboratory tests that are out there that might be helpful in the future to diagnosing antiphospholipid syndrome. I do not use these in my practice. I think we have yet to validate any sort of diagnostic criteria beyond these laboratory assays. And so I don't send testing for any of these other developing laboratory studies, although that may change in the future. The other thing to remember is that some of these assays can be influenced by the presence of anticoagulation. So that lupus anticoagulant assay is a functional assay, so it cannot be accurately tested when a patient is on anticoagulation. The antibody test, so the anticardiolipin and the anti-beta-2 glycoprotein 1, can be tested when a patient is on anticoagulation. But remember, those levels fluctuate. So to confirm the diagnosis, they have to show persistent elevation above the diagnostic threshold at a time point and then a time point 3 months later. So it is a very challenging diagnosis to make. The newest update in antiphospholipid syndrome is that, unfortunately, there have been a couple of trials now that compared the oral 10A inhibitors, primarily rivaroxaban, but there was recently a small study with apixaban, to warfarin. And the patients on the oral 10A inhibitors had an increased risk of thrombosis, particularly arterial thrombosis, compared to warfarin. So my current practice is that in any patient with antiphospholipid syndrome, I do keep them on warfarin rather than one of these newer agents. That being said, there's some debate about this. So there are plenty of patients in the world who have antiphospholipid syndrome and have been on these DOACs for many years and done well. So at least in talking with peers in hematology, we're not necessarily changing people who have been stable. But I do, when I have a new patient that is a new start with a new diagnosis of antiphospholipid syndrome, prefer using warfarin over the newer agents. And we already mentioned this before, particularly that, so if you have a patient with antiphospholipid syndrome that's going to transplant, I do consider bridging these people. So using an agent like heparin or enoxaparin, but that depends on renal function, because these people with antiphospholipid syndrome, surgery or any interruption in anticoagulation can cause catastrophic thrombotic complications. So we have to be very careful with them. And so I do bridge. Any questions on antiphospholipid syndrome?
Perfeito. Muito obrigada. Tá tudo ótimo.
Perfect. That's great.
Okay, good.
Oh, it's fine. No questions. It was clear.
Do you have enough?
No, I think
Actually, this is her last slide based on that, baseado nas perguntas. Agora pode ter tempo para mais perguntas se alguém tiver. Qualquer coisa, vocês já viram como ela sabe de tudo. You know everything.
I believe that warfarin, as you say, it's the best option for our patients because it's safer and it's sold, it's cheap. But so Beriplex is the best option to reverse.
Right.
Reverse.
Se diz INR, se diz INR, não me lembro mais dizer INR.
Sim.
Se o INR está assim, acima de 5, acima de 6, 7, um pouco de plasma congelado, como vocês dizem, vai ajudar, mas quanto mais baixo estiver, principalmente abaixo de 3, não tem volume de plasma que vai fazer a diferença. Aí é que fica. Como a janela terapêutica, como a janela terapêutica é entre 2 e 3, espera-se que a maioria dos pacientes estejam abaixo de 3. Abaixo de 3 o plasma é só para perder tempo, para dar volume que o paciente não precisa, o efeito vai ser mínimo.
Isso é importante. Então, só quando com RNs muito elevados, vai ter benefício.
Não vai normalizar abaixo de 2, mas vai baixar um pouco, enquanto o Beriplex está sendo ordenado, ou se há tempo de esperar.
E o manejo do Beriplex, então, é ir medindo e
guiado pelo RNI.
Isso. How to manage the PCC is to measure INR. 15 minutos depois da dose, se ainda estiver acima de 1,5, que em geral já é 1,5, abaixo de 1,5 tem hemostasia, hemostasis. E se está acima de 1,5, uma outra dose menor de 500, em geral o Beriplex vem aqui, pelo menos, vem em 500 e 1.000, os vidros. Não
Priscila sabe quanto é que vem aqui, Priscila.
Aqui também.
Aí também. É porque é a mesma companhia, mas para nós se chama K-Centra. Mas é o CSL Behring. It's the same company, different names. Na Europa e no Brasil se chama Beriplex. E aqui foi aprovado mais tarde, tem outro nome. Mas a gente compra vidros de 500 unidades ou de 1.000 unidades. Então, se ainda precisar mais uma dose, depois daquela dose inicial, uma dose de 500, e aí checar de novo. E depois, a cada 6 horas, um tempo de protrombina para ver se... Porque vai subir de novo a meia-vida do half-life. Meia-vida do fator 7 é só 4 a 6 horas. Então, o fator que mais afeta o tempo da protrombina é o fator 7. Então, assim, vai baixar o tempo de coagulação, aí aos poucos vai subir de novo. E aí tem que dar outra dose até que, como a Jori falou, o fígado comece a fazer os próprios fatores, se não for. Pelo menos os pacientes de vocês não têm cirrose. Aqui está a maioria dos pacientes que a gente usa o Beriplex tem cirrose, sangrando, então tem que dar. With cirrhosis, you have to keep giving it. Porque o fígado não é capaz de... Fígado is liver, hígado.
A equipe até está assistindo a doutora Maria Lúcia ali, transplante de fígado. Então, assim, a gente tem também o transplante hepático, eles realmente têm muito mais experiência, porque eles usam bastante.
Sim,
já estão acostumados.
Porque eles não podem contar com o fígado para fazer os fatores de coagulação. Pelo menos quando o fígado funciona, e a vitamina K foi dada inicialmente, 8 a 12 horas depois, o fígado deve ter começado a fazer.
Uma coisa que eu acho que eu perdi, a gente precisa repetir a vitamina K. I missed.
O que é?
Is it necessary to repeat
não é necessário to repeat vitamin K. Não. If you give, se for dar 10 miligramas, eu vejo às vezes darem assim 1 miligrama ou 5. Tem que dar 10 miligramas. E não intramuscular, ou subcutâneo, não. Oral ou intravenoso.
Well, and the important thing is to remember in cirrhosis, so in liver disease, the INR is not necessarily, you don't necessarily want it to normalize because you get a coagulopathy of balanced loss of, prothrombotic and antithrombotic proteins. So it's most challenging in those liver transplant patients, and we worry about overdosing them with PCC by trying to correct an INR to normal because they are already prothrombotic.
Right. The the antithrombotic factors, protein C, protein S, antithrombin, todos os outros que são anticoagulantes naturais também estão baixos. O fígado é mais complicado ainda, claro.
Aproveitando, já que os outros não têm pergunta, eu tenho todas. Preference between heparin low weight or the conventional one? I don't remember in English.
Yeah.
Yes. Is it better for our uremic patients? I mean, after the transplant, if it's necessary to restart.
So low molecular weight heparin, we use enoxaparin. You may use dalteparin.
I think they use enoxaparin.
Do you use enoxaparin?
Enoxaparina que vocês usam?
Sim, nós não tem dalteparina.
Okay. We use enoxaparin too, and if the renal function is in appropriate range, usually if the GFR is less than 30, we worry about using full dose in those patients. But if the GFR is appropriate, I prefer
above 30 you would consider appropriate.
Yes,
okay.
would use enoxaparin because it provides a more consistent level of anticoagulation and doesn't require, all the fluctuations you have with IV heparin can be really problematic.
We use once daily dose, right?
We use twice daily.
We're still using twice.
Yeah, so we use patients? 1 milligram per kilogram twice daily for therapeutic dosing.
Even somebody with renal.
Full anticoagulation.
Yeah, above 30. Okay. Yeah, GFR, tu entende GFR, né? Glomerular filtration rate, claro.
Sim, a gente sabe.
Acima de 30 duas vezes por dia. Abaixo, but if it's below 30, when do you use 1.5 milligrams per kilogram once a day?
I usually do that as an outpatient only.
Oh, okay.
So, but if you have a lower GFR, then you really have to use the IV unfractionated heparin because it is not dependent on renal function for clearance. And so that's going to be your best option. The other time you might use IV unfractionated heparin over enoxaparin is if you are extremely concerned about bleeding because it does have that, you turn it off and it decreases, the effect stops. You also have the option of using protamine, which protamine can be used with enoxaparin, but it's not quite as effective at reversing. So it's a little bit of a balance. So I guess I would say in those people where I'm extremely concerned about bleeding, I stick with unfractionated heparin, or if there's a renal function issue. If we think they're relatively stable, I worry more about thrombotic risk and I want a consistent level of anticoagulation, then I would use enoxaparin.
Yeah.
Perfect.
I think what I worry about, o que eu me preocupo mais na heparina intravenosa é que é tão fácil de esquecer de continuar. Se alguém manda parar por alguma razão, o paciente tem que fazer alguma coisa, ou alguma coisa acontece no andar da UTI, e aí para
a bomba.
Como é?
A infusão.
A infusão. Obrigada. Se para a infusão e fica, alguém esquece de recomeçar, passa 4, 5, 6 horas, 8 horas, o paciente volta a ficar hipercoagulado.
Sem falar que tem que ficar fazendo o KTTP toda hora. É bem difícil. Não sei se as pessoas têm mais perguntas, se a audiência aqui tem, ou...
Acontece muito de parar.
Se você tem alguma pergunta? Ou se o pessoal que está no Meet querem perguntar mais alguma coisa, Priscila?
Adorei.
Quer perguntar alguma coisa?
Muito obrigada.
Patrícia está falando.
Muito obrigada, foi ótimo.
De nada, Patrícia.
May I ask?
Claro, Maria Lúcia.
No, please. I'm so sorry. I couldn't hear your speaking from the beginning because I was in surgery. But I'm not sure if you talk about thromboelastography or rotational thromboelastography and the practical use, because we have in our institution in the liver transplantation, we really base it on those results. What's your opinion about that?
Yeah, so it's a controversial test in a lot of ways. I think the one place that it really has been helpful is, as you say, is in liver transplant, when we're really using it to make decisions about what additional products might be needed, because those tests like the INR, PT, and PTT are not as reliable. What I worry about is what we see at our institution is using the TEG outside of that context in areas where it hasn't been studied in place of validated tests like the PT and the PTT. So I do think it makes sense in the liver transplant setting and using that as your best gauge for what products the patient needs. But if the patient is stable on the floor, this is after, acute surgery, or a patient does not necessarily have a liver issue, I tend not to use TEG and I stick with the validated assays.
A maioria da experiência com TEG aqui na sala de cirurgia. Então, os anestesistas são os que mais entendem fora da sala de cirurgia, outside of the OR.
Right.
Se usa muito pouco, mas eu acho maneira que a gente pensa que quem tá acostumado a usar e interpreta os diferentes parâmetros e usa, é a melhor pessoa para continuar usando. Não tem dúvida que o teste é mais abrangente, porque é whole blood. Os outros testes de laboratório separa o plasma das plaquetas, das células vermelhas. O TEG usa todo o sangue total. Mas o problema para a gente que não está dentro da sala de cirurgia é que a gente não tem prática, não tem experiência com eles. E foi o que a Jori disse.
Obrigada, Marisa. Muito obrigada.
De nada. Aqui a gente usa TEG, praticamente não tem road TEG nos Estados Unidos. Algum lugar tem, mas é muito raro.
Well, I believe.
Como eu sou a representante do banco de sangue, não da área de clínica como vocês, representing blood bank. Meu comentário é que plasma congelado é raríssimo. A indicação para plasma é muito rara. É quase nenhum paciente deve receber plasma hoje em dia. As 3 indicações seriam a transfusão maciça, se tu precisa 5 a 10 ou mais unidades de precisa plasma. Aí o paciente está sangrando, o volume não é problema. CIVD com sangue, com sangramento significativo, porque também a falta de coagulação, deficiência de múltiplos fatores. Insuficiência hepática aguda com sangramento também, porque também tem falta de tantos fatores, como a Jori falou. O Beriplex só aumenta os procoagulantes. O plasma, pelo menos, também vai dar proteína C, proteína S, antitrombina, todos os outros fatores, inclusive fator 5, que não é dependente da vitamina K e que baixa bastante em cirrose ou insuficiência hepática aguda. Mas em outras situações não existe sempre uma coisa melhor, como Beriplex, ou mesmo crio precipitado, quando o problema é fibrinogênio, o maior problema é fibrinogênio.
Excelente. Eu acho que a gente pode encerrar.
Okay.
And again, thank you both very, very, very much. You are so kind.
Tchau, Patrícia.
And we enjoyed a lot.
Okay.
It was very, very useful.
Well, thank you.
Thank you again.
Thank you for having me. it was wonderful to meet you all, and thank you to Dr. Marques for bringing us together. And if I can ever be of help, please let me know, and I'll bother her to translate for me. So
Thank you very much. Marisa, muitíssimo obrigada. Foi maravilhoso. Então, em nome aqui do Kidney Transplant Team, I thank you both very much.
Eu vou mandar por e-mail os slides para a Rosana. A Rosana passa para vocês todos. E vocês têm o e-mail da Jori, vocês podem mandar um e-mail para ela diretamente também.
Claro. Thank you again.
Tchau, obrigada.
Tchau, muito obrigada.
Boa tarde para vocês. Que não tenha
Tchau.
hoje. Sem ciclone.
ciao.
Tchau.
Tchau.